Third plenary? Good afternoon. Yes, you are right. You're always right, Clifford. So good afternoon, everyone, and we are starting the third plenary. I hope that you can take your seats in order to minimize the sound. So we were talking in the first plenary, and it is not that just me that is going to be on the stage, but there is some kind of preparation that we need to follow. So in the first plenary, we were talking about different kinds of managing, I would say, information. In the second one, it was around meta networks and how to deal with that. In the third one, it is around innovation. And you remember that I used a quote from Ignatius Loyola, and I said that my name, Iñaki, comes from that. And I'm going to use another quote from Ignatius Loyola. And it is dangerous to make everybody go forward by the same road, and worse to measure others by yourself. And I think that is tremendously important also. And also I need to remind you that Ignacio Loyola was not the name that he used when he was born. In fact, he was Íñigo Oñez, and Oñez means walker. So he did a path, but it doesn't mean that we need to follow the same path. Another thing is we are talking about innovation, and there are many definitions around innovation, and you are going to be exposed also to, and I wanted to know also your opinion about innovation, and this is something that is important to us. But I'm going to use a definition of innovation from a foundation in Spain, and they were saying innovation is any change based on knowledge. Not only scientific, and in the previous symposium we have seen that there is not only the data, but it's also the opinions that are important. And one of the things it is that provides value, not only economic. So we are going to use a Slido. I don't know if we have the chance to have the QR on the screens. And I wanted to have some kind of survey to you. And we are going to make the first question. I don't know if we can have the Slido, the QR, with the questions. Not prepared? Not prepared? I don't know if perhaps I need to move. Yeah? Oh, that was the case. It was me. Okay. Okay. So, but I don't think we have the Slido. Yeah, it is down. So the first question is, define in one word innovation in health. It's not working? Come on. Come on. Technology not working. Innovation is not working. I'm amazed. No? Not working? So different opinions? So we can have different opinions around innovation? It doesn't work? No? Okay. So we will go ahead on that. So the second question that I had to you, it is, what do you expect from an innovative health technology? And this is another question that is important also. And perhaps those are things that we are going to address in the next plenary. So bearing in mind that innovation in plenaries is not functioning, we will jump on the next thing. That is presenting why we are talking about here, about innovation, and there are new ways to demonstrate value of innovative technologies. I'm going to expose you to a man that I met some time ago to talk about this, and he will present something about how to address things and how to try to demonstrate the value of innovation from a different perspective. So I'm congratulated to present Miguel Hernán. He's professor of Harvard and director of Harvard Causal Lab. So it is not by causality that we have Miguel Hernán talking about casualty. So it is please, Miguel, come to the stage. And I hope these slides go.
Thank you, everybody. I'm going to be talking about a particular type of innovation in health, since we are unleashing it. I'm going to be talking about how can we have better methods? How can we innovate in the methods to generate the evidence that we need for HTAi? And I would like to very, very briefly to go over what is the state of the art now. So, well, first, why methods for causal inference? I don't really need to answer this question because HTAi is a lot of it is about causal inference. Causal inference is just a fancy term to refer to methods to find out what works or how much it works compared with alternatives. So a lot of HTAi is about causal inference, call it comparative effectiveness, if you want, or comparative safety, when we're talking about what harms or how much it harms. The people who are in charge of HTAi agencies and the people who are in charge of the health systems need to decide based on the benefit risk of different causal studies. All this evidence is coming from causal studies, whether they are randomized trials or observational studies using real-world data. Because, of course, we all love randomized trials. I do. If I can choose, that's what I will have, other things being equal. But we cannot have randomized trials for every single question. It's just not possible. There are too many questions and too few euros or dollars. So think of any of the questions that you are working on. We cannot have a randomized trial for every population of interest, for every comparator of interest, for every time horizon of interest, for every outcome of interest. So we're going to have to use real-world data. And this is not a choice. It's not even our preference. It's the only thing that we can do. So all these discussions about whether trials are better or worse than real-world data, randomized trials versus observational studies are really boring discussions because this is something that is not a choice. It's not that we can choose between one method or the other. For many things, we are not going to have trials. And if we want to make decisions based on human data, the only thing we can do is use human data, and that data will come from non-interventional studies. So how can we use observational data, real-world data from, say, from electronic health records or insurance claims to make causal inferences in 2024? Well, there are some things that we have learned over the last decades. One is that it helps if we specify what is the hypothetical randomized trial that we would like to conduct, the target trial. And after being very clear about what is that trial, then we try to emulate it in an explicit way using the observational data. By doing this, first, we know what our question is. Many of you are used to PICOS, which is like an early version of the target trial. It's not precise enough for many of the questions. And then once we know the question, then the methods for the analysis of the data in many cases flow naturally from the question. So that things like many biases that are very common in observational studies, like bias due to immortal time, bias due to selection, don't even happen. They are totally prevented by doing this. There are other biases left, of course. We have confounding because there is no randomization, there is measurement error, there are other biases, but at least all these biases that are due to an incorrect design are eliminated by being very clear about what the target trial is. And our group and others have been going over big failures of observational causal inference in the last few decades. It turns out over and over and over, the main problem is design more than data. So after doing that, once we have questions that are more precise, that have to do with strategies that happen over time. We're not talking just about giving a vaccine today or not giving it, but how do you implement a particular treatment strategy that is sustained over time. Once we are asking those questions, which are most of the questions that we actually ask, then we need to deal with the fact that our treatment variable is going to be time varying. Therefore, our confounders are going to be time varying. We're going to have, in many cases, treatment confounder feedback, and that means that we need to use methods-based methods that are designed specifically to deal with treatment confounded feedback. We cannot use a Cox model with the variables there. We cannot use propensity score matching. All those things are for very simple questions about point interventions, really. Once we have these questions about sustained treatment strategies, we have to use G methods like the G formula, IP weighting, or G estimation, which are methods that have shown over and over that they can deal with time-varying confounders. And then, when possible, we can benchmark the data from the estimates that we get from the observational data. We can benchmark with existing trials, so that we use trials as an anchor, and then we can extend inference from the trials with the confidence that we have already been able to benchmark the results from those trials. Now, the thing is, yeah, but can we really trust observational emulations of target trials? So, as I said, there are two ways of creating more confidence. One is when there are trials, benchmark, then extend. And the other thing is when there are no trials and there are observational studies, what happens when we do the observational study first and then a trial is conducted? Because this is one of the main uses of real-world data, is to guide decision-making during that period in which we still don't have trials, but decisions have to be made. We cannot say, oh, we're going to wait for the trials, because that's making a decision, which is no action. So there are actually very few examples. This may surprise some of you. There are very few examples of observational studies that got it wrong after an explicit emulation of a target trial and the use of G methods. It's actually hard to find those examples. And many of the well-known examples that you may know of failures of observational data, like hormone therapy and coronary heart disease, or statins and cancer, all those things, it's been proved how after emulating a target trial and using G methods, all those discrepancies disappear. Those were not failures of the data, or failures of how we used the data. So there are many examples. I'm going to give you very, very briefly a few of observational studies that were later confirmed by trials. In fact, just one relatively well-known example now, when the guidelines for the use of antiretroviral therapy for people with HIV were being designed, the guidelines were based on observational studies. Lauren Kane and Sarah Lodi led some of these studies. There were no trials. The guidelines were changed. The trials were finished later, and they confirmed what the observational studies found. During COVID is actually the first year of the COVID pandemic is when real-world data and observational studies were most helpful. A lot of you may think about, wait, hydroxychloroquine, that was a disaster. Yes, it was. That was a very bad observational study. Many of those things should have never been published. They didn't follow the guidelines that I am describing here. But if you think about things that tocilizumab, which was shown in the late spring of 2020 in observational studies to lower the risk of mortality by a lot in critical patients at the ICU with COVID, this was later confirmed by trials. If you think about anticoagulants who were also studied in observational studies and were found to have no effect in COVID patients, it was later confirmed by trials. Plasma therapy, the same thing. It was later confirmed by trials that it didn't work after being shown in several studies, and this is including one in the VA system in the US. Boosters, boosters, when the decision was made to give a recommendation to everyone to get boosters for the COVID vaccine, that was based on observational studies only on real-world data from healthcare systems, in this case from Israel. And the decision was made, fortunately, because that saved thousands of lives in the late summer, fall of of 21. A trial was finished in December of 21 when it wasn't very helpful because the Delta variant didn't exist anymore, and it confirmed what the real-world data said. So my point here is that we have to move beyond this debate of randomized trials versus observational studies. They are not competing. These are not competing methods. They are complementary methods. We need both. We need both for different things. There are some cases in which, as I said, we can use the observational effect estimates while the trials are happening to have something to guide decision-making. In that case, there is this other very clear example of the decisions about using screening colonoscopy for colorectal cancer. For years, all the countries that were implementing that was based on real-world data and mathematical models that were not trials. The trials are now coming up. They are confirming exactly what was found in the observational studies. And then there are some times in which we will have the trial estimates, and that can be used to design better real-world data studies. One very clear example is the COVID-19 vaccines. We had phase 3 trials in the fall of 2020 that gave us benchmarks to design observational studies. In fact, practically all global vaccination policy after that time was based on real-world data. It was because trials could not give information about rare outcomes. They could not give enough information about safety, not in clinical subgroups, and the trials were done even before the alpha variant existed. Then we have alpha, delta, omicron, etc. All that information on comparative effectiveness and safety came from real-world data. So we are using it. We are using it, and it's not. It's been helpful for us. And this is actually is reflecting on how many organizations are starting to use this way of thinking. There are several research organizations like the Cochrane collaboration. The FDA Sentinel group has made a recommendation to use the target trial framework. There is now a paper open for public discussion by the European Medicines Agency, where the target trial framework is central. There are several HTAi agencies that are doing this in the UK, in Canada, in Catalonia. Maybe the next version of the EU health technology assessment rules will include this too. And there is a group that is working. There is an international group based in Sydney that is working on the development of standardized guidelines for the reporting of target trial emulation. So this is happening. It's a type of innovation that may speed up the generation of evidence. And I'm going to stop here. Thank you very much. I look forward to continue the conversation.
Okay, I'm now asking the panelists to come to the scenario. Yeah, please. So we are nowadays seeing that innovation it is a factor of how we approach to that. We are nowadays to have 5 people on the stage. You know the first one, Miguel. But I wanted them to introduce themselves, if they can. I know that the full CV, it is in, well, not the full CV, but at least the bio, it is in the program. But I wanted them to introduce themselves.
Okay. Hello, my name's Annette Brownack-Mayer. I'm the head of the School of Health and Society at the University of Wollongong in Australia. And we were asked to say something about ourselves that was not in our CV. So if you play the flute, I sing and I play the pipe organ.
Hello,
Quentin.
I'm Quentin Pankhurst. I'm a professor of physics at University College London, but I'm also the founder of several spin-out companies working in medical devices, one of which is Resonant Circuits Limited that I'm representing today. And I'm a keen bird watcher.
Hello, my name is Diego Gil. I am from Colombia. I am the president of Colombian Federation of Rare Diseases. And it's an umbrella organization that works for the inclusion, integration, and for the comprehensive care of the people with rare diseases in Colombia. And I'm also the president of ERCAL, Rare Diseases in Latin America and the Caribbean.
And hidden skills?
No, I don't. Maybe later. I'm going to think about it.
Maybe with a mojito. Anais?
Good morning, I'm Anais Gonzalez. I'm part of...
She is the responsible of not delivering boxes in your house.
Yeah. I'm part of Amazon Web Service, that is the cloud side of Amazon. So unfortunately, I don't have information about your package, and I don't know how to help you, just to be clear. But I drive the business development in precision medicine and oncology in AWS. I cover Europe, Middle East, and Africa. And well, I don't think it's so spectacular like my colleagues, but I'm a storyteller. Specialized on Venezuelan old tales and keeping let's say the history of our country for kids living outside of Venezuela.
And you have seen here that there is a chair, there is no one. We have a hidden invitee, and it is generative AI. So we are going to make the first question, that is, what is innovation in health, if it runs? And we have done it is not me that I'm in need to do. Sorry, I'm the one that is not innovative here. So we wanted to ask, what is innovation in health to artificial intelligence? Yep, not going? Come on. It is not that fast as we thought. No? Come on.
That shows that technology sometimes needs a little bit of change management.
It is the chair
side.
needs to be kept. It is going? May I? No? Not going? Come on. It's so frustrating. It's so frustrating.
I think it's an excellent example.
Okay, so let's go. If artificial intelligence is not going to tell us what is innovation, we will start, and this could be a problem. Let's start with Diego. So from the perspective of patient, what is innovation?
Okay, I think this is a good question and a complex question. From our perspective, I think that health innovation has a good relationship, an important relationship in improving the well-being of the people, not only related to the medical issues, but also related with the social issues, because it's important to take into account that the patients have different needs, not only related to physical conditions. So the innovations has to take part of this opportunity in order to provide different solutions to the people that have special needs, not only related to the physical conditions, but it's also, I think that it's important to consider that innovation in health must implies the characteristics of the people that are included in the different strategies to solve the different needs. It's important to know what are the conditions, what are the profile of the people that will be in which we can have the different strategies that we're going to have. It's important that the characteristics of each population can be known, their specific needs, their expectations, their profiles, the educational level. It's important to know how is the process to access to the different health services in the places where they are located, because we have people that are located in different regions where they do not have any kind of access. So it's important to take into account these kind of things in order to provide solutions to the different things that the people need. And also, I think that it's important to take into account that the innovation health initiatives include that the people cannot be, or the strategies cannot be implemented just or only for one stakeholder. It's important to include different stakeholders in the health sector. We have an important experience in Colombia, for example, a collaborative project where we join efforts with different health service providers and the industrial pharmaceutical industry and different academia, scientific societies, and patient organizations in which we work in order to design a model for a pathway in order to provide the health services that require the patients with rare diseases in Colombia. In Colombia, we until this time we don't have this model implemented, so we can provide this kind of information if we contribute and if we join together in order to provide different solutions to the expectations and needs that patients are really needing today.
I had a plan B, so nowadays I tested with my tablet, and I've asked the generative AI, and she was saying, innovation in health refers to the development of new or improved products, services, processes, or technologies that aim to enhance the quality, efficiency, and accessibility of healthcare. This can include advancements in medical devices, pharmaceuticals, digital health solutions, care delivery models, and other healthcare-related innovations. So, what do you think about that, Annette? It is a correct definition? It embraces also some other aspects or not?
Well, who am I to disagree with the bot? But I would say, I think there's a nice connection between the new, which is the key word there. The key word is that word new at the beginning, because innovation, I think, does require that something is new. But the way in which it is new, Diego has already alluded to the fact that what is new in one context and for one group of patients will not be new in another context. So the application of something that is routine in one setting could be an application that is new in a different setting, and that would still make it innovative. So for me, that definition is lovely, but it falls apart if you don't have that word new right at the beginning of it.
Yeah, and what about from the position of innovator? So someone that is knocking the door of the system, and you are receiving normally not good answers. And in the past, at least, it was just a no or come tomorrow. So Quentin, tell us.
So from the rather narrow perspective of the innovators, you know, from the universities, I'm used to having an audience where everybody is on the supply side of the innovation, and I think that from that perspective, innovation in health is some sort of magic black box, which is very hard to negotiate, and it's extremely hard to actually get an innovative new concept or solution or process or material or engineering practice into clinical practice. It's an amazingly hard thing to take what on the face of it looks like an incredibly good idea and get that actually into real world use. One of the difficulties that I think is also that from the patient perspective, when we talk to patients about this, a new potential treatment, the response is very positive. Yes, let's have it, and that then generates impatience about why is it taking so long to get there. So I think that there's a great deal of there's a well of purpose, wanting to do better in terms of innovation in health, and there's a tremendous difficulty in actually making it happen. And there's an enormous amount of money being spent on R&D, enormous.
But do you think that everything is innovative when you are moving in your field?
I can't quite hear you.
No, I was saying that, do you think that everything is innovative when you are moving in your field, so when you are doing a new development?
So I work in an SME, and I think most of the work that we do is not the incremental innovation, but more so to me, an innovation is something which is a new idea. I'm thinking about platform technologies, things which may have application in a whole variety of different indications. And then, of course, you have to, so I've benefited from the early HTAi, the early dialogue with yourself, Iñaki, around trying to identify the best route to getting that innovation into use. But there's an art to that, which is not very easy for the root and branch research scientists and engineers to actually grapple with.
And Ais, bearing in mind what artificial intelligence has said, and also being exposed to a big company, not delivering packages, but storing our data, and we were conscious of that. What is your opinion about innovation and from that perspective?
I think that there is completely agree on my colleagues, especially on the new, and especially in how this create a value or an impact in at the end in the patient and in the citizen. I think I will separate two things. So there is innovation that comes from knowledge, research, R&D, and let's say outside of the hospital, that tends to be very disruptive, and you need to add some kind of change management to make sure this new innovation can be adopted in the healthcare system effectively and really create a value and an impact at the end. And there is a second type of innovation that usually comes from the needs, from the challenge, and from the problems that the system itself is facing. And I always use the same example. When I was working in the hospital, nurses resolve a lot of different problems along the day with very innovative solutions that no one really value because it seems so simple. And this second part of the second type of innovation is what I think we have trouble sometimes to identify, because it's not necessarily so disruptive, it's not necessarily so, let's say, sexy, and we tend to have difficulties in identifying this second part, what comes from the challenge from the healthcare system, how they solve the problems by themselves.
They have told me that I don't need to use any more plan B. Seems to be that plan A will go. And the second question, hopefully, yeah.
It's a problem with the screen. You have it.
Yeah. Seems to be that it's going. Otherwise, we will go to the plan B once again.
It's there.
Let me see. No. Okay, let's go to the plan B once again. So the second question was to the lady that is not seated here. From an HTAi point of view, the assessment of innovative health technologies typically considers factors such as, and she said, clinical effectiveness, the ability of the technology to improve health outcomes compared to existing options, safety, the risk profile and potential adverse effects of the technology, cost effectiveness, the value for money provided by the technology, taking into account its costs and benefits, budget impact, the financial implications of adopting the technology within the healthcare system, and the last, patient, it's coming. Yeah. And the last, patient and societal perspectives that impact on patients' quality of life, as well as broader societal and ethical consideration. The lady has appeared, finally. So based on that, what is missing? So it is, Annette, what is missing here? She's certainly quite intelligent.
I think what is missing here is that the definition or the explanation given there isn't actually asking the question, what makes this innovative? Because it assumes everything that HTAi does is assessing something that is innovative. So it feels to me as an ethicist, and I care about individual words, that innovation here is just different, not necessarily new, nor necessarily better applied. And so I would think that one of the things we need to do in assessing innovations is first to ask ourselves, what is it that makes this innovative in the first place? Because lots follow from that. Either if it's innovative, if it's not really innovative, then we've got an awful lot of evidence and knowledge out there that we can apply to the new problem. If it is truly innovative, we're going to have a paucity of evidence and we need to tackle things in different ways.
Thanks, Annette. And from the patient's perspective and HTAi, what is missing? Because it puts patient and societal perspectives.
I think it's important that the innovation in health could give the response to the needs that have some populations that are historically neglected as isolated. It's important to take into account that we have to promote the reducing or try to reduce the inequity with different communities, because today we also have some communities that, for example, live in rural areas and they don't have any kind of access to different health services. So we need to work on that, and I didn't see this kind of perspective in this answer. So I think this is the challenge, include all the people and to promote the equity in the solutions that we can provide through innovation in health.
And do you find, in accordance to the definition, any kind of missing domains?
Did you come? Sorry, I was... Oh.
They are fighting each other. That is very human. They are fighting each other. So who is first? Miguel, go ahead.
So this talks about effectiveness and safety. It talks about the risk-benefit. It takes for granted we know how to assess those things. So I would also, by focusing on the words, is what is the meaning of clinical effectiveness? And not surprisingly, I'm talking about methods again. But let's say that we say, oh, we are going to conduct only randomized trials and do an intention to treat analysis. In a trial where there is a lot of non-adherence, that's not going to give us a valid measure of clinical effectiveness for the health system. So that definitely is not what we want to look at, or not the only thing that we want to look at. So this is all based on the assumption that we have good methods for the evaluation of effectiveness and safety. With that, it's not bad.
And Annette, you wanted to have your quota? No, but on the basis of that definition and how they have approached, because it is different how generative AI is approaching, depending on which is the perspective. Here we have tried to focus on, from the perspective of HTAi, how you define innovation and how you capture the value. But from the perspective of companies, I would say, do you think that is fair?
I think that from the perspective of the company, I think one of the things that I've taken from the meeting is the difficulty in identifying the comparators. And I also was very struck by the comment about how in the definition of the HTAi, it's about the life cycle of the technology. And how you made the point, Iñaki, that with drugs, the molecule doesn't change. So that life cycle of the technology is the life cycle of its use, whereas with medical devices, you've got incremental changes in the effectiveness, the technology that's embodied in that, and that I think is very difficult to actually, I don't see that written in this definition here. So I think that if things are really new and there's no obvious comparators to be made, then this is where this whole thing about the real world evidence, and which I guess is just another way of saying the post-market surveillance comes in.
And I have something to add?
To be honest, I think it has been covered by my colleagues.
Yeah, but we have said very interesting things and features, and we are realizing that the artificial intelligence the generative artificial intelligence that we have used, at least is not exposed to the new definition of HTAi, because there are many terms that are missing there. One it is environmental aspects, another one it is life cycle. So many things that are missing. So it is be cautious when you are using that. So the third question, and hopefully we have the answer. So the question was, can we demonstrate the value of innovative? Can we demonstrate the value of innovative technologies through real-world evidence? No, that is the next one. He's going faster than me. Let's do it. Yes or no? We have the plan B, just in case. No, that is the previous one. So let's go. Yeah. Can we demonstrate the value of innovative technologies through real world? Let's see what they are saying. Yes, real world evidence can be a valuable tool in demonstrating the value of innovative health technologies. Real world evidence refers to data collected from sources outside of traditional clinical trials. We have a lecture there, such as electronic health records, patients, registries, and claims data. Real-world evidence can provide insights into the real-world performance, safety, and effectiveness of innovative technologies, which can complement the evidence from clinical trials and support decision-making by healthcare payers and policymakers. Miguel, what to say?
I think it's copying from my talk.
It has been at the last minute.
All right. Yeah, no, I think that of course we can use real world evidence for HTAi. In many cases, is the only thing we will be able to do. We need to see it as a complement. It's not the only thing. We probably, if we demonstrate something that is surprising to us, we need trials to confirm afterwards. And sometimes, as I said, the trials will be done first, and we have to extend the results of the trials to different outcomes or populations or lengths of follow-up or things. We can do a trial that says that this works very well during the year that the trial was been done, and it lowers the risk of heart disease for a year. Okay, how about 5 years or 10 years? We're not going to have trials for that. We will need to be using real-world evidence. First, we need to show that we can reproduce, we can benchmark the results from the trial for 1 year. If we can do that, then we'll be more comfortable using this data for 5 years. But that is going to be the game, I think. Health systems generate huge amounts of data, and that data needs to be used. There is also the question about whether the health systems can generate the data in better ways so that it can be used better.
Yeah, and we are saying real-world data, real-world evidence, registries. Patients are claiming for that. How it is the use of that in different contexts? Diego?
I think that real-world evidence can provide useful information. It's complementary. However, I think data couldn't give us all the answers that we need. So it's important to include or to be in touch with the patients and families and caregivers in order to know all the information related to their needs, their experiences. Behind every data, you can find faces, you can find human beings with some complexity or complex experiences in the patient journey. You can find people with feelings, with expectations, with needs, and with some fears. So it's important to contrast the information, the data, with the experiences with the patients. For this reason, it's very important to involve all the families and the caregivers and the patients in all the stage in the process of HTAi, on every process that could include any possibility to develop any kind of therapy or drug or technology in order to reach all the expectations, in order to reach all the needs that all the people are needing in every time.
And Annette, real-world evidence, registries, challenges.
So I think the first thing that I would say is, and based on work that I've done in the last few years myself, working with community groups on public perceptions and perspectives on secondary use of health administrative data, is that in general, I think communities, as opposed to just patients, expect that data are going to be used for more than individual patient care, and that that's part of being a responsible collector, holder and user of information about patients. However, they also, and this is across so many studies now, place lots and lots of conditions on how data can be or ought to be used. And those kinds of conditions, I think, probably require us to think very carefully about how we are going to use real-world data in a way which maintains the social license to use it. So I'm thinking about things like privacy controls, data security, ensuring that priority populations and marginalised groups are not stigmatised by findings, ensuring that there's equity of access to evidence, and I could go on for longer, but those kinds of things I think are important, and they don't appear at all in that particular definition.
And Quentin, we are saying yes to real-world evidence, but we are still asking you to provide trials in terms of going to the market. So
well, it's certainly true, and I think there is there's a difficulty in terms of how one might frame and utilize that real-world evidence from a device perspective. Very frequently, devices are used as adjuvants to standard of care, and it's not that straightforward, to my mind, to parcel off the incremental benefits of using a particular device in a particular situation, particularly if you've got a heterogeneous population of users. So I think there's a real minefield in there. On the other hand, from a device SME perspective, where we have regular audits with the notified body, where we have to show evidence that we're following the clinical take-up of the technology, having more of an awareness of what the real-world evidence might look like for a given indication could be helpful.
Yeah, but nowadays you know Miguel, so he will solve all your problems, because he will make some kind of observational study by which you will demonstrate the value and reduce the uncertainty. Miguel?
Yeah, something that is also missing in this conversation so far is that if we're going to be using real-world data, we need research on the limits of real-world data. We need a systematic research program on what can and we cannot do answer with certain types of data. And that is not there yet. So there are a lot of people telling you, sure, we can use real-world data. It is the solution to many things, which is the simplified talk that I was giving to. But the truth is that there are questions we cannot answer with real-world data. And it's very hard to publish that. Our group is doing that. Sometimes we find a question of a trying very, very hard. Using all these fancy methods that I was talking about, you conclude this question cannot be answered. Because, for example, you cannot estimate the effectiveness of colonoscopy screening on overall mortality using administrative data. It's just not possible. There's not enough information to adjust for confounding. We were using it with Medicare, using machine learning, any fancy method that you do, and our conclusion is this cannot be done. This is a question, if you want to answer this question, you need a trial. It was impossible to publish that because people don't want to publish something that is wrong, which means that all this work, I mean, we eventually published it, but all this work about saying, look, there are some questions, we have spent 6 months doing it, please, everybody else, do not spend six months, it doesn't work, move to trials. Because there are some questions that cannot be answered with real-world data. And we need a change in the way that people think about what research means, about journals, and the editors of journals understanding that there is value in providing evidence about what cannot be answered using a certain data source. And this has to come together. Otherwise, we run the risk of having real-world data everywhere as if it were the solution for everything, and it is not.
I think Annette wanted to comment anything.
The only observation I was going to make is that one could say exactly what you've just said and substitute real-world data for clinical trials. There are plenty of things that we cannot answer with clinical trials, either because it's unethical to run the trial, or it's impossible to run the trial, or it would take too long to run the trial. So it really is about appropriate methods for appropriate situations.
Totally with you.
And Anais, do we have sufficient capacity to storage that amount of data and so on? And yeah, what do you think about this?
I will, from the capacity perspective.
And also the environmental impact that collecting data generates in terms of water consumption. And yeah.
I think here is, for me, is one step before answering that is, have we analyzed the kind of data and the kind of questions we want to answer? And for example, I work a lot in precision medicine, meaning genomics and pathologies. So it's very common for me going to a hospital, talking about a biobank that they have been storing samples, blood samples for quite a time, let's say that way. And they want to transform that in a genomic biobank. And you spend a lot of time basically trying to make them understand that probably that's not the best way to do it, not from the economical perspective, not from the technical, but especially not for the patient, because the results will be awful considering certain conditions for blood samples in biobanks. So what sometimes it's like we have this obsession of have data, and I know it's ironic because I'm coming from a cloud provider company that our business is data, but I try to make my customers and my clients to reflect in what really makes sense and what are the questions they are trying to answer in line with what Miguel was saying. Coming back to your question, sustainability is a big discussion for all type of data-related business. In the case in particular of AWS, of Amazon, we have a commitment in sustainability. I know that there is a lot of faces like, really? Yes, really? I feel your pain. I mean, I can understand where your doubts are coming from. But for example, all the data centers that we have in the world are using green energy, have new technology to reduce the use of water for refrigeration, one of the biggest impact of data centers. And I doubt that many of the data centers that are running in public institutions I will talk about Spain because I'm based in Barcelona, has invested the amount of money we have invested to reduce our carbon footprint in the Zaragoza region, for example.
So the problem is that we are Diogenes. So we wanted to maintain data, and not defining which data is important. So it is, and I think, and also from the patient's perspective, do you think that we are collecting the data that is needed, or we are in many occasions focusing on administrative data that is useless? And apart from that, Anais is telling us that that could create an environmental impact.
Sometimes I see that we are focused on the administrative on data issues. For that reason, I say that it's important to put the patient perspective in front of the data. Data is complementary, data is very useful to make decisions, but it's not, it will not give us all the responses that we need. So it's important to include all the experiences, all the opportunities that we can have, or strategies in order to can have could have all the information that we can receive from the patient perspective. Because sometimes if we focus on the data, only in this kind of information, we can lose the useful information that we can receive from the perspective of the expertise of the patients and the caregivers. I think it's important to focus on that issue.
I think Anais wanted to complement.
So regarding that, I think we are seeing the change right now, because the focus in the data, I think it was more in structured data, meaning data that we can have in an organized way and we can access easily, for example, to do models. Now with the generative AI, that we can extract the information from unstructured data, meaning the clinical notes, the patient experience, that's a new level on how to gather information. And I think it will really change how we capture the information from patients, caregivers, but also professionals. That now it can be done in a human way and not in a structured way that is completely against our nature, let's say it that way, and how we relate our experience.
So let's go to the last question, and if it is me or if it is the AI, generative AI, and if it runs. Thinking. I have the plan B, just in case. Okay, the third question was, identify 3 challenges that healthcare systems will need to address when judging innovation. And the AI was answering, 3 key challenges healthcare systems may face when considering innovative health technologies include uncertainty and evidence gaps. Innovative technologies may have limited long-term data, budgetary constraints healthcare systems often face, and the last one, the plan B is failing also. Yep. So it is the regulatory and policy considerations. So they were uncertainty, we have seen, it was uncertainty, it was policy considerations, and the last one, budgetary constraints. Thank you, Magda. So the three challenges, budgetary constraints, regulatory and policy considerations, and uncertainty and gaps in evidence. Are you in agreement? Something missing, I think it is.
Yeah, I think the social license to innovate is the big missing thing, and that relates to trust between people whose data are being collected, if it's real-world evidence or trials, but trust between publics and health service providers, trust with government who are regulating services, trust with the private sector who are developing new innovations. That's the big missing element from my perspective.
Quentin, tell us. So it is budget issues. It is regulatory processes. It is.
So the question is about challenges that are facing the healthcare systems, and I think that from a medtech perspective, this capacity to take on new technology in the healthcare systems, because the training element for having a new intervention is not insignificant, and it requires a great deal of work from the companies to support that. But it also requires willingness and capacity amongst the healthcare professionals to actually take that on. And so you have this adoption curve where you've got the early adopters who are the people who are very keen to take on a new technology. We often talk about unmet need, but one of the difficulties from a medtech perspective is that an unmet need probably means that the current status quo is to not do it, is to do nothing. And that's an extremely hard thing to dislodge. Whereas a poorly met need, where there are people, where the professionals are faced with something which they know they have to do, but they don't like the way that they have to deliver it, that's a much better opportunity. And so it becomes very important to be thinking about how am I making the healthcare system's life easier by adopting this new technology. So I think that's another part of the challenge to the healthcare system, is capacity.
Diego, is just budget, or those are the challenges from the
I
patient point
absolutely
of view?
agree with the answer. However, I will include the equity. I think that the innovative solutions in health need to tackle or the needs of all the people. We have to reduce the inequity. All the people needs to have the possibility to access to different technologies, to different medications, regardless the location where they live, regardless the social, economical situation they have. I think this is an important issue, and we have to work together on that, not only local, national, regional, but also at a global level. And I would add some issue related to financial situation. We think we always need to add more resources to our health systems in order to tackle all the issues that we could have with the new opportunities for the new therapies that we could have, for example, in advanced therapies. So it's important to analyze. It's important to discuss all the different innovative sources that we can have to get all the resources that we need, or the health systems need, in order to have the sustainability along the time. And finally, I think it's important that to connect all the stakeholders in order to promote the access to the different clinical trials. I see, for example, in some countries in Latin America, we lose different opportunities in clinical trials because the recruitment is not successful because all the stakeholders are not connected. So it's important to connect all the stakeholders in order to take advantage of these kind of opportunities and to facilitate to the countries to access to the different clinical trials that are available.
Challenges, Anais.
So I think I will take this last part from Diego on the stakeholders, and I will include the data sources. There are so many sources of information that you need to use right now, and all of them are in silos. It's so difficult to connect that it's not only connecting the stakeholders, it's not only connecting all the actors. Sometimes it's basically connecting the data sources to be sure that you have the whole data set, let's say that way, to run Miguel's analysis, for example. And the second that I want to reinforce is the diversity, especially because our population are changing very quickly. And I wonder sometimes, again, talking about how Barcelona has changed in the last 20 years I have been living there, I wonder if my healthcare system is really prepared to address the difference that the population will have in the next 20 years, and how the HTAi process will include this diversity that we see now in the population. And it's an open question. I'm not being ironic. It's something that it really worries me, because I don't think we are making enough, we are not putting enough effort on that part sometimes.
We were saying in a previous panel, we were saying without data you are just a person with an opinion. And we were talking about uncertainty, Miguel, but it is that right? So it is, we can live with that level of uncertainty and lead to make access, or still there are things to be done from the methods point of view, and especially using this type of technology.
Yeah, the challenges that we read in this definition are all very important, of course, but there are pre-challenges, which is how to generate evidence from the data and interpret it with all this uncertainty. I strongly believe that health systems need to evaluate their own data to become better health systems. They have to be learning health systems. A lot of these issues about trust, about diversity, are partially solved by having health systems serving their own people with data that doesn't leave the health system, is there. And you have either an in-house team of experts or experts from outside that are working very closely with the health system, and they're under very strict privacy rules. But at this, once we think about this, how health systems become learning health systems, there are a lot of health systems out there that are making decisions based on data from other places only, and they don't use their own data, even though they have lots of it, and they could use it. The challenges there are, I think about comparative effectiveness about comparative effectiveness of safety research in 3 stages. The first stage is that you need to have a clear question. You have to ask a precise question. It cannot be just a pico question. It has to be a really precise question. Define what the experiment, what the target trial is in detail over time, all those things. And that's something that health systems, I think, can do. They have experts doing that, or they can work with experts. That's the first step, knowing what your target trial is. The last step is doing the data analysis that I described, using G methods, say, of things like that. And that's the easy part. That takes maybe 5% of the total time. Most of the time goes into the middle, which is what Anais was talking about. The middle part is how you map your question to the data in the health system so that you create an analytic data set that can be used to apply the methods that I described. That middle part, creating the data pipelines so that you can use the data in the system, that is 90% of the time. I know many people here work with data, and those who are in the trenches, on the data trenches with us, know what I'm talking about. That's really where what the biggest challenge is. How do you create within the health system a group of people who are working on that and saying, every time that I tell you what one eligibility criterion for my target trial is having hypertension, okay, how do I define that in my health system, and how valid is that, so that then I can use it in my analysis. And that is where this thing that we call AI now, that's where it could be very, very helpful, as you were talking about, reading clinical notes, etc. I hope that a lot of the effort in the next few years goes into that middle part, because that's really what is slowing down the generation of evidence. We know how to analyze data. I mean, a lot of people know, and some people don't, but they will learn. The difficult part is how to make the data ready for that.
Yeah, thanks. We have talked about challenges. I think there have been discovered more than 3. It was uncertainty, it was trust, it was inclusiveness, it was also stakeholders' involvement, it was the consciousness of making the good questions, and also the consciousness of getting the data. I'm also asking the audience to please send some questions. You can stand up and put on the microphone, tell us who you are, and then we will try to do our best in terms of trying to answer, or perhaps providing you more questions. Yep, go ahead.
Brendan Carney. I'd like to suggest that we don't consider all new technologies as innovative, and that we broaden that scope to include invention, innovation, and improvement. And perhaps there's some literature to suggest that if we look at it that way, it's better to understand the research and development pipeline and how we might assess the value of new technologies. And in my clinical areas, some examples would be, an innovation would be CAR T therapy, where a new cellular therapy is totally new to medicine, and where the outputs are potentially very significant, or outcomes, and where existing therapies are ineffective. Innovation might be an improvement in monoclonal antibodies, which we've been using for 25 years, and where we now have biospecifics, which can, in certain diseases, produce very significant improvements in outcome. An improvement might be a second or a third generation of a molecule, such as a TKI in chronic myeloid leukemia, where there are small improvements in outcome and maybe some reductions in side effects, and probably we would call that a better mousetrap. But I think it's useful not to call everything an innovation, but to think of that spectrum, because that helps us to assess the research and development pipeline and then the HTAi value of the HTAi in assessment.
Any reactions, or just saying yes? So in agreement, Brendan, thank you. Magda?
I have a question regarding the quality.
Please tell us who you are.
Sorry, Magda from Poland. I'm working also for oncological hospital in Poland, and my experience is very similar, that innovations is a broad, I think, spectrum. But for me, for real-world evidence, it's crucial, because the one thing is that we would like to identify the patients, questions that we would like to raise, and then look at the data. And what we see, at least, and it's a huge hospital, and we see the quality of care, how the patients are provided in the care. It's also impacting very much. Even that we have innovations which assess an HTAi and we put in the system, it's not innovation. It of course depends what kind of innovations we have. The smallest incremental, this is much harder to achieve. How are you dealing with the quality of care during the real world evidence? Because this is something that it's not easy to even measure, and this is my question.
Anyone wants to react?
So, see, health systems decide what they care about, and if they care about something, they have to invest money. If health systems care about quality of care, they need to measure, they need to generate data about quality of care. And that typically means they cannot collect information about quality of care from an interaction between, say, a patient and a physician if they are not willing to give the physician more time to collect that data. So it's really a question of what does the health system want to do? See, when we work with data from insurance claims, that's very fixed. There's not much that we can do with that type of data, much that we can do in terms of expanding the data. That type of databases are good for some questions, are not good for many other questions. They don't have enough clinical information. Many times we need very detailed clinical information to be able to adjust for confounding. But when it's data from electronic health records and for the health systems, then themselves, it's partly the responsibility of the health system to make sure that the data that they claim they need is being generated.
Yeah, I think we need to conclude. We are almost there. I think you have the last minute of glory. And I think Quentin wanted to be the first. Some thoughts. You can react, and perhaps you can finish with some thoughts to bring back home.
I think that this is fascinating, this idea about having the patient's voice in the electronic health record, and if that's something that becomes part of the future of the record keeping, I think that will make this real world evidence thing much more connected to picking up those qualitative and extremely important aspects of the ultimate outcome, which is the health of the patient.
Diego, the demandant in front of the innovation.
I think that the most important thing, or the takeaway that you need to have today, is to join efforts in order to include the information or the evidence that we can receive directly from the patients and the families, and to take advantage of the different tools that we have available at this time with real world evidence or artificial intelligence or anything that we can help in order to provide the solutions that we need for the different populations with the different diseases around the world. So I think this is the final message. The challenge, I think, is to connect the information, to connect the people, to connect the stakeholders in order to provide the right solutions for the people.
Nice.
So I will steal your phrase, indeed. And I also consider that connect is the key word here. It's connecting the data, it's connecting the stakeholders, it's connecting with the new methods. But especially it is important to make sure that in order to do this holistic view, let's say, and connect all this data, you also use the technology and the resources that are available. There are many things that we can do right now with the technology we have already that simplifies your life, and it's important. And don't get me wrong, that doesn't mean that you use ChatGPT for everything. I'm not saying that. But if you want to capture, for example, the real concept of the patient when they talk about the quality of care, it's something that it can be done without a questionnaire. It's something that can be extracted for a test. And that's the question for you that I have. How many of these new values are you using to measure and to keep that data?
Annette?
So I'm going to end on a cautionary note, I think, because one thing we haven't talked very much about is that innovation, or actually probably taking Brendan's idea of a continuum from improvement at one end through to discovery, invention at the other. The further one moves along that continuum, the greater the risk that there actually will not be an improvement, or that the improvement will be overshadowed by the harms. So I think we need to think about this as a balance between the potential for benefits for people balanced against an increasing amount of risk simply because we are dealing in a world with which we are not so familiar yet.
And finally, Miguel.
And I will add to what you just said, and cost, of course, yeah. But that's why the key aspect here is are we using the best methods that we have, and are we generating the data in the best way that we can to evaluate this effectiveness, safety, of course, cost too. And right now we see a lot of data out there that are not being used really. That is a waste. That's a societal waste, and we need to work together and with health systems and people in different parts of this stakeholder world work together to make sure that we are extracting as much high-quality evidence as we can, and things are looking good.
So thank you very much. We started the first day, and I said reach to excellence and share it. I think this is something that we have done so far these days. And I finished with the same quote that I've used at the very beginning. It's dangerous to make everybody go forward by the same road, and worse to measure others by yourself. And this is something that we need to understand, that there are different types of thoughts, different types of perspectives. And the thing that I'm gathering from this panel, it is make the correct questions, gather the correct data. We have the tools. Let's work together. Thank you very much.